This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 12, Neurological Emergencies. Introduction. Neurological emergencies can often be very difficult to manage. Signs and symptoms of neurological emergencies may range from headache to coma. The status may change rapidly from responding appropriately to quickly unconsciousness. Close observation and quick response are required for neurological emergencies. So, what kind of emergencies can we see in there? They may be traumatic or non-traumatic in origin. Drug therapy may be required, such as anticonvulsants to control seizures, and we use anticonvulsants at the point that the seizure is making the patient hypoxic. Antiemetics to limit vomiting, and antihypertensives to lower the blood pressure, and then overall steroids to decrease swelling. And there's mixed reviews on the use of steroids with swelling. Cerebrovascular accidents, or CVAs, or strokes, include strokes and transient ischemic attacks. Difference between a stroke and a TIA is a TIA resolves the symptoms with oxygen. So, CVA generally occurs from a clot or hemorrhage in the brain, and this causes weakness, paralysis, speech impairment, confusion, seizures, and coma. An ischemic CVA, a clot forms in the cerebral artery. Tissues distal to the blockage become ischemic. Can be treated with thrombolytic clotbusters, but there needs to be some very rapid things occurring whenever they get to the hospital to determine whether or not their clotbusters are contraindicated. Up to 3 hours after onset, the time of onset is well established so that we know exactly whenever it started if bleeding can be ruled out quickly. And they generally do this with a non-contrast head CT and radiologist interpretation. Treatment. Apply a stroke scale to confirm probability of the stroke, and this can be done in two forms: a Cincinnati stroke scale, which is the AHA's version, or the LA pre-hospital stroke scale, which is the current state protocol. Establish eligibility for thrombolytic therapy, and in this questionnaire they essentially figure out when the onset time is, what their overall blood pressure, what their history and their medications are. Transport to the closest stroke center, which would be a level 1 neuro facility. Contact at earliest opportunity so that you can activate the stroke team if necessary. Stroke centers have pre-designated centers with CT protocols and staff, and they're available throughout the state. Ensure approximate treatment based on evidence, appropriate treatment based on evidence, and should be the primary destination for all strokes. Window from onset of the actual symptoms is going to be 3 hours. A non-stroke center facility will only delay the treatment if you take them to it. CVA hemorrhagic stroke, and this is bleeding into the brain tissue, causes intracranial pressure and can give us complications. A large amount of pressure on there at the point that you get a midline shift can decrease respiratory patterns and all kinds of stuff. Treatment aimed at decreasing blood pressure. Now, whenever we decrease a blood pressure in hemorrhagic stroke, we kind of tend to look at what the intracranial pressure would be. So, the ideal scenario would be to have a intracranial bolt in place if we think ICP is developing, and then use a formula. Now, the general formula for the use of this, or to look at this, would be cerebral perfusion equals intracranial pressure minus the mean arterial pressure. And then your machines generally will give you this, and what that means is that the ICP is offsetting the actual perfusion of the tissues, and the cranial pressure is developed by that. So cerebral perfusion equals whatever is in the brain, the ICP, minus the mean arterial pressure. So whatever is left in deficit, if there isn't left in deficit, then the brain is not being perfused. Hemorrhagic strokes is bleeding into brain tissue. Treatment aimed at decreasing blood pressure. Traumatic neurological emergencies, subdural, epidural, and intercerebral hematomas. All of these can be devastating. Some of these, the subdurals, actually bleed slow because they're generally venous, and then the epidurals bleed quite rapidly because they are generally arterial. The intercerebral hematomas are in all of the nooks and crannies. So any space that there's in there, there's void, the blood will be just filling that area, and they develop intracranial pressure, but it's kind of everywhere. And a concussion, any loss of consciousness after injury, brain swelling, potential fatal herniation of the brain may actually occur. Preventative medications, and this is talking about the preventative therapy and getting people to where they don't make the actual embolic clot to begin with. And aspirin is a good way to do that, and that's because aspirin actually works on thromboxane A2 and stops the platelets from being sticky. So what that does is that decreases the size of the clot, because if each one of these are a platelet, and the more platelets that we have, the bigger the clot gets, that's kind of problematic. If the platelets, though, are slick to where they'll kind of bounce right by one another, or they don't aggregate as well as they once did, then that's kind of a good thing. So aspirin's a primary care medication, and acetylsalicylic acid, or aspirin being the trade name, mechanism of action on this, inhibits the formation of prostaglandins involved with the production of inflammation, pain, and fever. This also contributes to the analgesic effects. Antiplatelet activity powerfully inhibits platelet aggregation by blocking the formation of thromboxane A2, which causes platelets to aggregate and arteries to constrict. So the aggregation of platelets, or the clumping together, is what we attack whenever we give them aspirin. 160 to 325 milligrams PO, as I said before in other slides in this area, or this drug. If you are giving it via our version, which is baby aspirin, and this is the EMS version, please document the appropriate dosage. Pediatric dosage, precautions should be given in children with viral illnesses. An example of this is Ray's syndrome is what it will cause. Contraindication, hypersensitivity to salicylates. Bleeding disorders or thrombocytopenia, avoid during pregnancy, especially during the third trimester, because of the potential for adverse effects on the fetus and mother. Pharmacokinetics, onset 5 to 30 minutes, duration 2 to 3 hours. It's excreted in the urine. Thrombolitics, alteplase. So again, this is for the previous chapter, will help with this as well, but I'll do a quick overview of it. That any time that we take the preform of plasminogen and form plasmin, the plasmin breaks down anything that's made from fibrin. Now, fibrin is what we hold the actual clot together with, so this will essentially dissolve the clot. So anytime the active form of plasmin is made, it will dissolve the clot. Activase, primary care. Alteplase or Activase, mechanism of action on this, binds to fibrin in the thrombosis, causing a conversion of plasminogen, which is already there, to plasmin. This conversion results in local fibrinolysis, or breaking down of the clot, and a decrease in circulating fibrinogen. The thrombus is dissolved, which may limit the size of infarction during a myocardial infarction. Adult dose on this, total of 100 milligrams IV over 3 hours, and we've discussed this before. 60 milligrams over the first hour is one way to do it. Administer the first 6 to 10 milligrams of the 60 milligram IV bolus over 1 to 2 minutes, and the rest in that hour. 20 milligrams by IV infusion over the second hour, and then the other 20 milligrams by IV infusion in the third hour. Less than 65 kilograms or 143 pounds, a total of 1.25 milligrams per kilogram IV over 3 hours is followed. 0.75 the first hour. Administer those 0.075 to 0.125 milligrams per kilogram of the 0.5 milligram per kilogram by IV bolus over the first 1 to 2 minutes. 0.125 milligrams per kilogram by IV infusion over the second hour, and then 0.25 milligrams per kilogram by IV infusion over the third hour. So essentially 0.75, 0.25, and 0.25 milligrams per kilogram over each consecutive hour. 0.75 being the first hour, 0.25 being the second, and then 0.25 being the third. Pediatric dose is not recommended. Contraindications, any kind of active bleeding because we're fixing to bust apart any clots. History of CVA, intracranial or spinal surgery within the past 2 months, and that's because of bleeding that can occur. Severe uncontrolled hypertension or bleeding disorders. Pharmacokinetics, onset 30 minutes and half-life 72 minutes. This is excreted in the urine. Steroids, and this is something that is they don't use steroids so much to decrease swelling in neurological emergencies. We've had mixed results from that. As far as evidence-based medicine go, there's no real evidence, but in this book and in the National Registry, you might actually see questions related to that. So therefore, the two steroids that we're going to talk about are dexamethasone and methylprednisolone. And steroids do for us, they have an easy access pass across the cellular membrane, and they change the way that the cell communicates, developing new proteins, changes transcription. Very simply, it changes the packaging or the communication capabilities of the cells in general. Now, in doing this, we generally get decreased cellular mediated response when we're talking about the immune system, and we get an increase in potency of our catecholamines if required. Now, fortunately for us, this decreases swelling because of the inflammatory response of the immune system brings in tons and tons of cells to that area trying to repair it, but it kind of gets clogged, so swelling is actually increased when we have an inflammatory response. Now, generic on dexamethasone, this is general knowledge, is Decadron, and the major thing that I would like you to remember in this is the mechanism of action. Please, I could ask them in any form, whether it be dexamethasone or Decadron. So, mechanism of action on this. This is a long-acting synthetic adrenocorticoid with an intense anti-inflammatory or glucocorticoid activity and minimal mineralocorticoid activity, so it doesn't mess with sodium so much. As an anti-inflammatory agent, it prevents accumulation of inflammatory cells at the site of infection and inhibits phagocytosis, lysosomal enzyme release, and synthesis of selected chemical mediators of inflammation. Reduces capillary dilation and permeability and utilized to manage the inflammatory response seen in anaphylaxis. Also used for cerebral edema, but this is controversial. Adult dose 0.75 to 9 milligrams daily. Pediatric dose of 0.5 to 2 milligrams per kilograms daily. That's supposed to be a D. Daily. Contraindications, systemic fungal infections at the point that your immune system cannot fight back a fungal infection. That would be concerning. So any kind of systemic fungal infections, hypersensitivity, or cerebral malaria. Pharmacokinetics, onset 8 to 24 hours, metabolized in the liver and excreted in the urine. Solumedrol, primary care drug as well. Methylprednisolone is a generic on this, and the trade name is Solumedrol. Mechanism of action, intermediate acting synthetic adrenal corticosteroid with similar glucocorticoid activity but considerably fewer sodium and water retention effects than hydrocortisone. Its pharmacological actions are vast and complex, and in medicine have a wide range of uses. This is used for both respiratory emergencies. It can also be used to decrease cerebral edema. However, adult dose on this, 125 to 250 milligrams IV or IM. Pediatric dose, 1 to 2 milligrams per kilogram IV IM. Contraindication, no major contraindication in the management of acute anaphylaxis. However, risk versus benefit on cerebral edema. Pharmacokinetics, peak effects, 4 to 8 days. IM duration, 1 to 5 weeks. IM half-life, 3.5 hours. Metabolized in the liver. HPA suppression in 18 to 36 hours. Hypoglycemics, and you can have altered mental status from low sugar levels. Dextrose 50% comes to mind. Generic on this is Dextrose 50%, and the trade is the same, Dextrose 50%. Mechanism of action, this is already in its appropriate form. Dextrose 50% water increases circulating blood sugar levels to normal. That's because half of the solution in here is dextrose or sugar, C6H12O6. Also acts briefly as an osmotic diuretic. Very simply, that's because of a very large molecule. Adult dose in this, 10 to 25 grams of dextrose 50% in water. And again, I'll say this, that we normally do 12.5 to 25 grams because it's easy just to give half or whole. Pediatric dose, pediatric greater than 2 years old, 2 milliliters per kilogram of D50. Pediatric less than 2 years old, 2 to 4 milliliters per kilogram. And again, this is in milliliters. of a dextrose 10% in water solution. Now, again, it's easy to, if you'll squirt out half of the concentration, or the 25 grams, it turns it into 12.5 grams. And then very simply, if you'll pull the rest of the fluid in there and dilute it one more time, it's actually, instead of 25 or 50%, if we'll squirt out 3/4 of it, so half would be, it's 50% to begin with, so it would be half would be dextrose 25%, and 1/4 of this would be dextrose 12.5%. Now that's pretty easy to administer, so if you squirt out 3/4 or leave 1/4 of it left and pull the rest up with fluid, you've diluted it with 3/4 of the amount of water. So 12.5 versus 10%. It's usually pretty easy to get that to your patient at that point. So squirt out 3/4 of it, suck up normal saline, dilute it, and then that would be dextrose 12.5%. 2 to 4 milliliters per kilogram if they're under 2 years of age. Contraindications: do not administer D50 to patients with intracranial hemorrhage. Pharmacokinetics: onset less than a minute, duration dependent upon the degree of hypoglycemia, and this is metabolized as carbon dioxide and water. Anti-seizure medications. We're going to talk about several of them here. Diazepam, Fosphenytoin, Lorazepam, Phenobarb or Luminal, Phenytoin, and then Versed. So the Gaba receptors and how this works. Let me do a brief overview of this here really quick. So membrane potential, you have sodium potassium pumps and channels that are all kind of stretching through the cellular membrane. The inside of the membrane is negative in nature, and that would be in its resting spot. So it has sodium potassium pump movement to increase the action potential charge to where it's more positive, and then once it reaches a certain positive level, it fires off an action potential. It's reached threshold, so now it can actually function. So what the GABA channels do is they are a chloride channel, and what that does for us is whenever we stimulate the GABA site, gamma aminobenzoic acid, which is a natural CNS depressant, what it does is it opens this up and makes this more permeable to chloride. So chloride starts coming in. Well, chloride is negative. So if we're trying to attain that action potential, we'll have difficulty with it due to a negative presence or negative charge inside the intracellular compartment. And that's what the GABA does for us through the chloride ion and through the chloride channel that we see here. Stimulating that GABA site would bring more chloride and more negativity into the intracellular compartment, which would decrease the amount of action potential that was there. Now, we utilize this. All of our benzodiazepines work like this. So Versed, Valium, Ativan, all of them are a benzo. So what that does, some of them are more potent than others. So what that does is that robs you of the ability to generate an action potential. And if you're having a seizure, thereby decreasing your overall seizure activity. If you don't have enough energy to generate the action potential, then you won't have a synaptic firestorm, so to speak. So diazepam, primary care. Generic on this is diazepam, and the trade is Valium. Diazepam is a benzodiazepine whose exact mechanism is unknown, but many believe it appears to act on both limbic and subcortical levels in the CNS. It is primarily used for its anticonvulsant properties. It suppresses the spread of seizure activity through motor cortex of the brain. It does not appear to abolish the abnormal electrical discharge foci. It is also used as a sedative in the management of stress, anxiety, and to treat the withdrawal symptoms of alcohol. Diazepam is an effective skeletal muscle relaxant, making it an effective adjunct in managing orthopedic injuries. It is also useful as a pre-medication for minor surgeries and cardioversion because of its induced amnesia, which diminishes the patient's recall of the procedure. Adult dose on this for seizures is 5 to 10 milligrams and may be repeated every 5 to 15 minutes as necessary for a total of 30. May be administered IM if unable to obtain IV access. Adults, skeletal muscle relaxant is going to be 5 to 10 slow IV bolus or IM. Elderly or debilitated skeletal muscle relaxant, 2 to 5 milligrams slow IV bolus or IM. In pediatrics, pediatric seizures greater than 5, 1 milligram slow IV bolus or IM every 2 minutes for a total dose of 10. Less than 5, 0.2 to 0.5 milligrams slow IV push or IM every 2 to 5 minutes for a total dose of 5 milligrams. Pediatric skeletal muscle relaxant, 0.2 to 0.5 milligrams per kilogram, slow IV bolus or IM. Maximum doses greater than 5 years of age is going to be 10 milligrams. Under 5 years of age is going to be 5 milligrams. Contraindications, hypersensitivity to diazepam, benzodiazepine, or propylene glycol, pre-existing CNS depression of any sort, and acute narrow-angle glaucoma. Onset of this drug is going to occur in about 1 to 5 minutes, and the duration is going to be 15 to 60 minutes, and this is excreted in the urine. Fosphenytoin, this is a general knowledge drug. Phenytoin is a sodium channel blocker, and we have it a little bit later. But again, the sodium channel that we're talking about is synapses. So by reducing or blocking the sodium channel, they don't have the ability to generate the action potential to begin with. Fosphenytoin is converted into phenytoin after administration. It then acts to decrease seizure activity by altering ion transport and decreasing synaptic transmission. And this is a sodium channel blocker in doing so. General knowledge, all I need you to know is the mechanism of action on this. Lorazepam, primary care. Generic on this is going to be Lorazepam. And the trade name is going to be Ativan. Mechanism of action, Lorazepam is the most potent of available benzodiazepines. Its effects, anxiolytic, anti-anxious, sedative, hypnotic, and skeletal muscle relaxant, are mediated by the inhibitor neurotransmitter gamma-aminobenzoic acid. Action sites include the thalamic, hypothalamic, and limbic levels, CNS. Lorazepam has a shorter half-life than diazepam and is used as a pre-medication for cardioversion in minor surgeries because it induces amnesia and the patient's recall of the procedure. Like diazepam, it suppresses the spread of seizure activity by the motor cortex of the brain while not abolishing the abnormal discharge focus. Because of its short half-life, it is the preferred drug for pediatric seizures. Unlike diazepam, lorazepam is water-soluble and can be easily diluted for administration. Adult dose on this for seizures is going to be 0.05 milligrams per kilogram IV bolus, maximum dose 4 milligrams. Do not administer faster than 2 milligrams per minute. Initial dose may be repeated after 10 to 15 minutes. Do not exceed 8 milligrams in 12 hours. Pediatric dose, not recommended for the pre-hospital use, but it is the preferred benzodiazepine of choice for pediatric seizures because of the half-life, and we'll talk about that. Contraindications, hypersensitivity to lorazepam or other benzodiazepines, pre-existing CNS depression, acute narrowing glaucoma. Do not administer in pregnancy or lactation. Onset is in 1 to 5 minutes, duration 6 to 8 hours, and is eliminated in the urine. General knowledge on this one, which this is luminal or phenobarbital. Phenobarbital, long-acting barbiturate and sedative, and hypnotic effects of barbiturates appear to be due to primarily with its interference with the impulse transmission of the cerebral cortex by inhibiting the cellular activating system. Phenobarbital has no analgesic properties, and small doses may increase reaction to painful stimuli. CNS depression may range from mild sedation to coma, depending on dosage, route of administration, degree of nervous system excitability, and drug intolerance or drug tolerance. Phenobarbital limits the spread of seizure activity by increasing threshold for motor cortex stimulation. Barbiturates are, however, habit-forming. And this is general knowledge, so that was the only section that I needed you to know, which is the mechanism of action. Phenytoin, general knowledge. And I will just break this down. A class 1B, which is a sodium channel blocker. Phenytoin is a hydrodentoin derivative chemically relative to phenobarbital. Its precise mechanism of anticonvulsant action is unknown, but it appears to reduce the voltage, frequency, and spread of electrical discharges within the motor cortex, resulting in seizure activity inhibition. It also has Class 1B antidysrhythmic properties similar to those of lidocaine and tocamide, also Class 1B agents. In abnormal tissue, phenytoin causes a slight increase in AV junctional velocity, depressed by digitalis glycosides, prolongs effective refractory period, and suppresses ventricular pacemaker automaticity, and may slow conduction or cause complete block in abnormal ventricular fibers. Again, this is a general knowledge drug. Versed, primary care. Generic on this is going to be midazolam, and the trade is going to be Versed. This is also a Gaba agonist or a Gaba stimulant. Midazolam is a short-acting perennial benzodiazepine with CNS depressant, muscle relaxant, and anticonvulsant, and an antigrade amnesic effects. Its exact mechanism of action is unclear. Intensifies activity of gamma-aminobenzoic acid, or GABA, a major inhibitory neurotransmitter of the brain, by interfering with its reuptake and promoting its accumulation at neuronal synapses. This calms the patient, relaxes skeletal muscles, and in high doses produces sleep. Like the other benzodiazepines, it has no effect on pain. Midazolam has considerably less muscle relaxant properties than that of diazepam. Adult dose on this is going to be 1 to 2.5 milligrams slowly, IV, 0.07 to 0.08 milligrams per kilogram IM. Usual dose is 5 milligrams. Pediatric dose of 0.05 to 0.20 milligrams per kilogram IV, 0.10 to 0.15 milligrams per kilogram IM, or 3 milligrams intranasal. Contraindications: midazolam is contraindicated in patients with intolerance to benzodiazepine, acute narrow-angle glaucoma, shock, coma, and acute alcohol intoxication. Used with caution in patients with COPD, chronic renal failure, CHF, and the elderly. Pharmacokinetics: onset 3 to 5 minutes and duration less than 2 hours, and it is excreted in the urine. Alright, antihypertensive, and some of these are just general knowledge. We're going to talk about labetalol, nitroglycerin, and nitroprusside. It is not really suggestive that we alter the blood pressure of a patient without understanding what their intracranial pressure might be, because we could cause hypoperfusion of the brain tissues. So labetalol is a general knowledge drug, and again, I want you to be able to know what type of drug it is, and it is a beta blocker. Do not administer labetalol to patients with a hypersensitivity to labetalol, bronchial asthma, or congestive heart failure. The drug itself is a LOL, which means it's a beta blocker, decreases contractile force strength of the heart and rate on this medication. This would be something that they would use in the emergency room to bring down someone's blood pressure before administering something like TPA or a clot buster. Nitroglycerin. This is what we most normally have in EMS. It's kind of losing favor in adjusting blood pressures, though. So we need to keep perfusion to the axial tissues. The state protocols removed the antihypertensive or emergency hypertension or hypertensive emergency protocol from being in play. So if you're out there and you feel like that you need to, you may give nitroglycerin, but you'll have to call. Please check your local protocol. Generic on this is going to be nitroglycerin. Trade name is nitrobid or nitrolingual. Mechanism of action: nitric. It is a nitrate. Nitroglycerin is a nitrate, organic nitrate, with potent vasodilator and anti-anginal, anti-ischemic, and antihypertensive effects. It relaxes smooth muscle by an unknown mechanism, resulting in a dose-related dilation of both venous and arterial blood vessels. It also promotes peripheral pooling of blood, reduction of peripheral resistance, and a decrease in venous return to the heart. Both left ventricular preload and afterload are reduced. Adult dosing on this is 0.3 to 0.4 milligram tablets, or via nitrolingual spray at 0.4 milligrams per spray. The IV bolus, 12.5 to 25 micrograms, followed by an infusion. This is in many forms. There's transdermal paste versions of these. In the ointment, 1 to 2 inches every 8 hours, up to 5 every 4 hours. And then the transdermal patch, 2.5 to 15 milligrams and 24 every 24 hours. Pediatric dose not recommended in pre-hospital care. Contraindications. It's going to cause hypotension, so keep that in mind. Or it will bring down their blood pressure by vasodilative activity. Do not administer nitroglycerin to patients with hypersensitivity to drug, head trauma, hypotension, hypovolemia. Do not administer to patients in shock. Do not use in patients with severe bradycardia or tachycardia. Nitroglycerin should be administered to patients taking medications for erectile dysfunction disorders because of potential of fatal hypotension. If they already have been taking things like Viagra and Cialis, those medications do the same thing. The reason most people have a problem with erectile dysfunction is because of the amount of perfusion that is occurring to that appendage. So by giving nitroglycerin and vasodilating them even more, we have a loss of containment. Whenever patients are taking 12, 24-hour versions of erectile dysfunction drugs or the 36-hour version. Pharmacokinetics, onset 1 to 3 minutes and duration up to 30 minutes, excreted in the urine. This is going to be nitroprusside, and this is a general knowledge. We're looking at the mechanism of action on this. Direct vasodilator affects both the peripheral venous and arterial smooth muscles, which reduce both preload and afterload. Nitroprusside increases the capacity of venous circulation and reduces blood pressure indications. This is a nipride drip, essentially. We may see patients actually on this quite a bit whenever they're in the hospital to reduce the blood pressure in an acute setting. Osmotic diuretics are mannitol, and mannitol isn't used much in EMS, that's why it's a general knowledge drug, but a very large molecule substance that pulls fluid out. Now, mannitol is an osmotic diuretic that, through its hypertonic effects, a very large molecule, thick substance, draws water into the intervascular space. Then it induces diuresis by raising the osmotic pressure of the glomerular filtrate, thereby inhibiting tubular reabsorption of water and solutes. It's an effective way to reduce intracranial pressure and cerebral edema. In large doses, it may increase the rate of electrolyte excretion, particularly sodium chloride and potassium. Mannitol reduces elevated interocular and cerebral spinal pressures by increasing plasma osmolarity, thus inducing diffusion of water from these fluids back into the plasma and extravascular space. Vasopressors, norepinephrine. More specifically, this is a gigantic, big alpha-1 agonist. Now, the generic on this is norepinephrine, and the trade name is Levophed. This is a primary care medication. Norepinephrine stimulates primarily alpha-adrenergic receptors to result in a potent arterial and venous vasoconstriction. This action increases blood pressure. Norepinephrine stimulates beta-1 adrenergic activity to increase cardiac contractile and cardiac output. Adult dose in this begin infusion at 0.5 to 1 mic per minute, and this is dose per minute again. Increase until there is a therapeutic effect while maintaining a blood pressure at or above 90 millimeters of mercury. The average infusion rate is 2 to 12 mics per minute. However, patients in refractory shock or per medical control may need to be taken up to 8 to 30 mics per minute. Pediatric dosing, 0.05 to 2.0 mic per kilogram per minute, IV. Maximum dose is going to be 2 mics per kilogram per minute. Contraindications: do not administer norepinephrine to patients with hypotension caused by hypovolemia, myocardial ischemia, or infarction. Do not administer norepinephrine during pregnancy because of decreased uterine blood flow, presence of thrombosis, hypoxia, or hypersensitivity to norepinephrine or its bispholates. Pharmacokinetics: onset 1 to 2 minutes, and the duration is 1 to 2 minutes as well. Excreted in the urine. Conclusion: neurological emergencies presented in this chapter are frequently encountered in the out-of-hospital setting. Drug therapy used for neurological emergencies plays a secondary role to initial stabilization, rapid transport, detailed assessment of the patients, and early notification to the hospital. References for this chapter were taken from Beck Pharmacology for MS Provider, pages 103 to 125 of Delmar Learning, and Bledsoe's Pre-Hospital Emergency Pharmacology, 7th edition by Prentice Hall. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@emsa.net, or 45219-7613. Thank you.